Hello everyone and welcome to a new session of clinical pharmacology. Today we are continue speaking about the endocrine system. Our topic today, the second part two, will be on the will be focusing on the hypothalamus and pituitary gland hormones. So we're going to speak about RH hormone, IH hormone, and hormone release from the pituitary, the clinical use, mechanism of action, therapeutic and adverse effect, contraindications, and so on. Okay, starting with the first hormone release from the anterior pituitary lobe, we have growth hormone, and another name for growth hormone we need to be familiar with. This name called the somatotropin. So the somatotropin growth hormone. So we have two names: growth hormone or somatotropin. So we need to remember this name. Somatotropin stands for the growth hormone GH. Somatotropin released from the anterior pituitary lobe in response to the GHRH. We discussed that in part 1. So in part 1, in endocrine overview, we discussed the GHRH. So the GHRH stimulate the GH from the anterior pituitary lobe, and the GRRH also inhibited by the somatostatin. So what happened there in our body, if you speak about the situation or like controlling the growth hormone in our body? So we have two main hormone control the growth hormone in our body. The first one will be responsible for stimulation, and the second one responsible for inhibitory effect. The hormone responsible for stimulation secretion of growth hormone will be GHRH, and the one responsible for inhibition will be somatostatin SST. So you can see here the growth hormone under the effect of two hormones coming from the produced, synthesized, and released from the hypothalamus. We have GHRH, and then we have somatostatin. For this reason here, we see normal growth in the human body. So if anything happen in the growth hormone, increase or decrease, this will lead to the abnormalities. If you see the growth hormone increase, we are going to see acromegaly in adult, or we are going to see gigantism in the children. If the growth hormone decreased during childhood, so we are going to see the dwarfism, or like shorts of statures. Um, Growth hormone also an important topic for us to remember. Growth hormone in our body released in volatile manner. That means that the growth hormone will be high during the evening, during sleep. So the growth hormone will be high during sleep, and with the increasing age, when the people increasing age, the growth hormone will be decreased. What do you have in the practice here in general? As you can see here, we have in the practice recombinant DNA technology hormone. So you can see here in the practice, we have DNA recombinant technology hormones. Speaking about this hormone, somatostatin, growth hormone, recombinant growth hormone, recombinant somatotropin. Remember that another name. How this medication work? Growth hormone responsible for synthesis of a protein, so stimulate protein synthesis, stimulate bone growth, stimulate cell proliferation. So you can see all these, like we can call this one anabolic effect. Stimulate protein synthesis, stimulate bone growth, stimulate cell proliferation, and mitosis. The growth hormone administered like subcutaneous injection. Growth hormone could be used in children suffer from growth hormone deficiency, or for children suffer from the very short stature, maybe compared with the normal healthy children. Growth hormone, as you can see here, if we talk about children here, what about adult? We can use it for the adults suffer from the deficiency, growth hormone deficiency, or some patients suffer from HIV related wasting, or cachexia, like losing a lot of weight and physical waste and body mass. So we use it for GH deficiency and patient with HIV to as a replacement for the growth for this patient. Side effect: the growth hormone in adult may cause peripheral edema, myalgias, arthralgia, and carpal tunnel syndrome. We don't use it. CI stands for contraindicated. It's not recommended in children with a closed epiphysis. So because this medication enhance growth, and if the children already has a closed epiphysis, there is no way to induce growth in children. We don't use it in children with a closed epiphysis. So for this reason here, we need to do some diagnostic test before use growth hormone. For example, we cannot use this one in patient above 18 years or 20 years or 22 years because we have closed epiphysis and it's not working there. A patient with diabetic nephropathy, patient with some type of obesity pattern such as Prader-Willi syndrome. All this about the growth hormone, but we need to remember the main use for the growth hormone will be growth hormone deficiency, even for the children and adult. And other things, this medication prescribed subcutaneous only. Okay, moving to the next slide. Here we have a case when you have patients suffer from growth deficiency, and the growth hormone will be normal. So when you measure the growth hormone in patient, you can see the growth hormone is normal in the blood. Here they said the issue here could be in the target. The issue could be in the target, like insulin, like growth factor 1, and this may be available on the tissue cells, this receptor here, and they said that we have maybe some maybe deficiency in this hormone IGF, insulin like growth factors, and for this reason here they developed another medication. Instead of growth hormone, they developed a medication called recombinant insulin like growth factor 1, and this name, the medication name Micasermin. So Micasermin considered like recombinant insulin like growth factors, and you can see here we have the target growth hormone affect the target. This is that receptor here, so receptor for the IGF-1. So here this one represents the IGF-1. So the IGF-1 now bind to the receptor and induce the effect of growth hormone. So this medication used in children suffer from growth failure due to the deficiency in IGF-1. This medication prescribed subcutaneous. This medication, again, similar to what we have in the growth hormone, is not prescribed to the children suffer, maybe has a closure epiphysis, or some patients suffer from malignancies. This medication may cause a risk of hypoglycemia. Okay, so the situation here to try to prevent the hypoglycemic effect, we recommend to use this medication in injectable subcutaneous before or after meal directly to prevent hypoglycemia. So we prepare this Micasermin injection, then we take our food. So we have meal here, we have our meal, then we have the injection. So we take the injection, then we take our meal. So it's like direct at the same time. Or this is before, or could be directly. So we take our meal, after the meal directly we take the injection. So what we have here, they recommend to take Micasermin before or after food directly to prevent hypoglycemic effect. Let me click on this link here and to share with you what type of information do you have about Micasermin. This 30 pages about Micasermin and the brand name Increlex, and as you can see, Increlex, Micasermin, recombinant DNA technology there. This medication given injectable subcutaneous, indication and usage for this, you can see it here. This medication prescribed for children for treatment of growth failure in children with severe primary IGF deficiency. Okay, or if the children suffer from growth hormone GF gene deletion, who have developed neutralized antibodies to the GH. So the main reason here we need you to remember the patients suffer from deficiency in the IGF hormone. Okay, again, what else we need to remember here about this medications? About risk of hypoglycemia. Okay, so you can see here warning and precaution. The first one for us in this table here, Increlex or Mecasermin should be administered shortly before or after. Should be administered shortly after or before meal because it has insulin-like hypoglycemic effect. From the name, insulin-like effect. So the main effect of this hormone, the side effect will be hypoglycemic effect. Okay. This is the second one. The third one here. So what we have here, we have growth hormone. We can we discussed the first one, growth hormone, somatotropin. Okay, and use it. The second one will be mecasermin. We use it for patients from growth deficiency, growth failure due to the IGF deficiency. Moving to the next hormone is somatostatin hormone. Somatostatin hormone, here we have patients from acromegaly in adult or like gigantism in children. You can see here this called a growth hormone inhibitory hormone, growth inhibiting hormone, and this name somatostatin. Another name we can call this one growth hormone antagonist. So we have three names: growth hormone inhibitory hormone. We have somatostatin, another name, or we can call this one growth hormone antagonist. So we have several names for this one: growth hormone inhibitory, somatostatin, growth hormone antagonist. The issue here, they found their somatostatin bind to the somatostatin receptor, SSTR receptor, and suppress growth hormone mainly. So suppress this medication here. This medication suppress growth hormone mainly, as you can see here. Let me clean this one. Okay. The main effect of SST, the main effect to suppress growth hormone, and we have another effect to suppress TSH. Here we speak about hormone only, but if you remember, we covered that in the GI system, GIT system, and we already covered that by inhibit hydrochloride secretion. Okay, so we have list of maybe effect of somatostatin. Please remember, somatostatin considered like inhibitory hormones. Inhibitory hormone, you can see plus, sorry, I will type inhibit. So we can see here, we can call that somatostatin a somatostatin inhibitory hormone again. Inhibitory hormone for all the organs, growth hormone, TSH or GI system. We don't use somatostatin in clinical practice. Somatostatin has limited therapeutic usefulness because somatostatin has short duration of action. Number one, somatostatin has multiple effects, and this one remind us with the acetylcholine. The same, acetylcholine has a very short duration of action and has multiplicity of action. For this reason, we don't have acetylcholine in the practice. So the same situation applies for somatostatin. We don't use somatostatin because somatostatin has very short duration of action and has multiple effect on the human body. Clinical use, we use SST for the patients suffer from acromegaly in adulthood or to treat gigantism in children. We are going to share some slides with you regarding this issue. Okay, in the Google image, if you type acromegaly there and try to see what happened here, they compare between the patient with here we have the children with the gigantism, and you can see the hands for normal children before, and this is after the children affected by the increased level of the growth hormone. Again, you can see the situation here between for example, the hands for the patient here. The same situation, you can see the hands here for normal and abnormal or acromegaly The same for the jaw and the body. So all these related to the agromegaly. Some picture here for gigantism. You can see it here in the on the picture. You can see gigantism here for the children, and again this picture here, another picture here, there, and the same apply here, the gigantism. Okay. Okay, as we mentioned here, we don't recommend to use somatostatin in the clinical practice due to this effect here, due to the short action and multiple effect of somatostatin. What we can do here, the situation. Okay, so we can go with something else. So from this slide here, in this slide they try to remind us what we can use for the agromegaly or gigantism. We have two options. Number one, we go with the somatostatin analog, something similar to the somatostatin chemical. We have octreotide, lanreotide, then we have basirotide. This one considered like somatostatin analog. Then they came up with another solution by blocking the growth hormone receptor. So we have two options. Number one, to prescribe something analog to the somatostatin. We have octreotide, lanreotide, basirotide. Then we have growth hormone receptor antagonist. So you can see here we brought something like similar. We brought something similar to the growth hormone, to the somatostatin. Somatostatin analog, similar chemical, octreotide, lanreotide, basirotide. Okay, synthetic analog of somatostatin. Advantages: longer half-life. Use this medication for the patients from agromegaly. This medication we use it for the patients from a subtype of tumor which called a carcinoid tumor. The carcinoid tumor here associated with a severe diarrhea and flushing. So sometime when you have patients from carcinoid tumor, we can use octreotide, lanreotide, and basirotide. The patient may suffer from gallbladder abnormalities or gallstones with a long-term use of this medication. This medication is very expensive, and it costs a lot of money for the patient and the insurance. Moving to this is a 3 medication here. We have 1 and 2 discuss it. What about basirotide? Basirotide here selectively bind to the this one more selective. Bind to the specific receptor of somatostatin, receptor 5, basirotide. Bind selectivity to the somatostatin 5. This medication selectively inhibit ACTH secretion, and this will lead to the decreased secretion of cortisol. Wow. So for this reason here, what we have selective medication bind to the somatostatin receptor 5, decrease ACTH, decrease cortisol. For this reason, basirotide, we use it for patients from Cushing syndrome. So if you click on this link here, and they will take you to the basirotide. Read briefly about the basirotide, maximize the page. Okay, basirotide, Signifor, basirotide injection, subcutaneous. This medication used for adults suffer from Cushing syndrome, Cushing disease, for whom pituitary surgery is not an option, okay, or not curative. So we have the case here. So basirotide, this will lead it to the decreased secretion of ACTH, decreased secretion of cortisol. Okay. So we've done with the first hormones, the growth hormone, and we discussed the clinical use of growth hormone. We discussed the somatostatin. We brought up the megasermin, and then we have another important hormone related to the growth hormone. So we discussed the analog here, like somatostatin analog. What about other hormone? We have big vizumant. Big vizumant here. It's considered like a growth hormone receptor antagonist, growth receptor antagonist here. So what we have here again, we have the receptor here, growth hormone receptor, and the big vizumant try to bind to the receptor, and binding to the receptor here, big vizumant. What that mean for us? Another one. So we have the growth hormone here, and display the growth hormone. So it's a prevent growth hormone from binding to the receptor, displays the growth hormone from binding to the receptor. So big you see here, competitively inhibit the growth hormone. Big Vizumant, from the name, the first three letter Big Vizumant, BEG, stand for polyethylene glycol. Big Vizumant stand for polyethylene glycol. What is the characteristic? Longer half-life, that's great. Less immunogenicity, that's good. And we use this medication for patients from acromegaly. And this medication may cause abnormalities in or increase in liver function tests. So for this reason, we need to monitor the liver function for this patient during the treatment with this medication, Big Vizumant. Okay, I'm sharing the Google image with you now. You can see the Big Vizumant here, coming like a vial. We have several concentration for Big Vizumant. 10 milligram here, and we have another one here, Big Vizumant. We have 20 milligram, 10, 20, 30 milligram, 25 milligram, 50 milligram. We have in different doses, and if you click on this one here, so you can see the brand name, generic name. This medication prescribed subcutaneous, for subcutaneous injection only. So what is Big Vizumant? Okay, if you minimize, Big Vizumant considered like growth hormone antagonist. Big Vizumant used for patients from acromegaly. When you prescribe this medication to your patient, you need to monitor liver function. Okay, the second hormones we are going to speak about, they're related to the hypothalamus pituitary gland. Here we are talking about the anterior pituitary. The second hormone will be GnRH. GnRH stands for Gonadotropin-Releasing Hormone. So Gonadotropin-Releasing Hormone, we don't have this hormone in the practice. We have chemicals hormone related to the GnRH. We have agonist, that mean mimic, able to stimulate the receptor. We have gozerline, hysterine, leuprolide, naphthalene. I will repeat it. Gonadotropin-releasing hormone agonist. We have 4 hormones. We have gozerline, hysterine, leuprolide, naphthalene. Okay, so again, as you mentioned, I will try to maybe address that again here. What we have, as you can see here, regarding the gonadotropin-releasing hormone, according to the gonadotropin-releasing hormone, GnRH here, GnRH, we have the agonist, that mean able to stimulate the receptor. We have antagonist, inhibit or block the receptor. Regarding the GnRH agonist, we need to remember the name, to know and remember the name. We have gozerline, hysterine, leuprolide, naphthalene. Agonist, stimulate the receptor. Okay, then we have antagonist, that mean able to bind to the receptor and block the receptor. We have GnRH, cetrorelix, digarelix. So you can see here the suffix relix, and this that mean, remember, the GnRH antagonist, relix. So what we have here, GnRH, cetrorelix, digarelix. Okay, regarding the agonist, we have reline, gozerline, hysterine, and then we have naphthalene. So we have reline for the agonist, and lex for the, or relax for the antagonist. Again, for this one here, if you look on the graph here or the image, you can see that GnRH release from the hypothalamus. GnRH release from the hypothalamus. GRH stimulate the pituitary gland. The pituitary gland will release the FSH and FSH, and this will stimulate the 6 organs. Could be in the female, affecting the ovary and produce estrogen and progesterone, or progesterone, estrogen and progesterone, or in the male, affecting the testis and induce or increase the release of testosterone. We have more detail about the male and female later on. Okay, speaking about the GnRH agonist here, we have, as you mentioned, we have gozerline, hysterine, and naphthalene. We know that this type of hormone released in the human body in pulse manner. So we have surge and stop, then released and stop. So we call this one pulse style manner. GHRH release as pulse style manner, and you can see here what we have when the GnRH release in pulse style. okay, we have surge of GnRH. So that what happened here? Stimulate FSH and LH. When this stimulated, this will lead to the increased level of estrogen and progesterone and androgen in male and female. So when you have it in pulse manner, that means we have increased level. So if you prescribe this group of medication continuously, if you prescribe it continuously to your patient, okay, the situation will be inhibitory effect. So we call this one negative feedback. So if you prescribe this group of medication, goserelin, hysterelin, ribulad, in pulse style manner, this will stimulate the pituitary, increase FSH and LH. If you prescribe it like continuous prescription, the result will be inhibitory effect. So you can see here decreased level of FSH, decreased level of androgen and estrogen. Clinical use for this medication for the GnRH agonist. Yes, we use it for treatment of infertility. We use it as okay for suppression of LH during the infertility treatment. We have details about that when you talk about the sex hormone, estrogen, progesterone. Okay, number one, infertility treatment to suppress the LH during the infertility treatment. We use it for the patients suffering from prostate cancer. We use it for patients suffering from endometriosis. We use it for the patients suffering from precocious puberty. Here, when you prescribe this medication, this medication, goserelin, hysterelin, novarelin, agonist GnRH, so we expect the female or male hormone to be high or like inhibited. So it depends on the situation, pulse or continuous. Here we are going to see some cases of hot flushes in both men and men. You can see it here, hot flushes. You can see sweating, ovary cysts, depression, gynecomastia in male, decreased libido in male. Okay, so this is what we have about the GnRH agonist. We need to remember the four medication: goserelin, hysterelin, leuprolide. This medication has two main mechanism of action. If you prescribe it like pulse style manner or continuous manner, then we move to the side effect or clinical use: infertility treatment, prostate cancer, endometriosis, precocious puberty. Moving to the second group of medication with the relax. With the relax here, we call this one GnRH antagonist. So GnRH antagonist here, we are talking about the three medication: GnRH, cetrorelix, digarelix. Okay, this medication decrease level of LH and LH and FSH. So GnRH, cetrorelix, digarelix decrease level of H and FSH. This medication could be used for the treatment of infertility, for the control ovarian stimulation. Okay, treatment of infertility. The two medication, GnRH, cetrorelix, treatment of infertility in during the control ovarian stimulation. Okay, moving to the next, the third medication, they said digarelix. Digarelix used for patients from advanced prostate cancer. So you can see it here, digarelix for advanced prostate cancer. If you speak about GnRH and cetrorelix, use it for treatment of infertility. So let us click on this one here, and this will take you to the digarelix. So you can see here digarelix. I like what they have here, trade name, digarelix. Okay, digarelix, let us maximize the page a little bit. Digarelix subcutaneous injection here, and if you scroll down a little bit and read the clinical use for this medication, this medication used for advanced prostate cancer treatment. Okay, so in this slide here, I will go back a little bit. So we have two main group of medication. We have agonist. We need to remember the name and the clinical use. Then we have antagonist. We have relax and the clinical name and the clinical use for each medication. So for example, from this slide here, which of the following medication belong to the GnRH antagonist and used for advanced prostate cancer? We have digarelix. Which of these medication belong to the GnRH agonist and used for patients from endometriosis? We have goserelin. Okay, let us click on this one here and go with the hysterelin acetate and the indication. You can see here hormone hysterine used for the treatment of children with the central precocious puberty. Okay, so we have it here. Okay, so we're done with the second hormone. So first hormone was growth hormone, and we discussed the growth hormone. We discussed the somatostatin, mecasermin, bigovizumab. Then we moved to the sixth hormone. We discussed the GnRH. We have agonist, antagonist, and we discussed the clinical use. The third hormone for us here, for the third hormone for the hypothalamus pituitary gland, we have the ACTH hormone, and we call this one gonadotropin. But before we go there, we need to remember what type of hormone will control this one. We know that CRH will stimulate ACTH, and this will stimulate the adrenal cortex to release cortisol. And what else? To release aldosterone and androgen. So you can see here we have the CRH control the ACTH, and ACTH release in pulse, and with a higher concentration in 6 in the morning. And we covered this topics in the adrenal cortex, adrenal gland in separate lecture. But this one very nice one to learn about it. Okay, then we have so the high level will be 6 in the morning, lowest level will be in the evening. Does that make any sense for us? Yes. When you try to prescribe this medication to your patient, ACTH, try to give maximum high dose in the morning and lower dose in the evening. And the purpose of that, to mimic the normal physiological secretion in the human body. So give the high normal dose in the morning and lowest dose in the evening. The receptor for ACTH will be on the cell surface receptor, G protein receptor, and ACTH stimulate release of adrenal gland. We have it there on the chart. You have it here. Okay. What we have in the practice, ACTH. So before we go to the ACTH clinical use, what is ACTH? The brand name for or generic name for ACTH, we have gonadotropin. So if you like to remember, COS for cortisone, cortisone, and tropin, this one belong to the hypothalamus. Before we go a little bit in depth, we need to differentiate between 3 types of adrenal insufficiency. For adrenal insufficiency, we have 3 types. 1, 2, and 3. The adrenal insufficiency could be primary. The lesions here, the disease will be limited to the adrenal cortex. So when you have primary adrenal insufficiency, the situation related to the adrenal cortex, the lesion, the disease will be located in the adrenal cortex. When you talk about secondary adrenal insufficiency, the disease will be located or limited to the pituitary gland. Tertiary adrenal insufficiency, we talk about hypothalamus. So we have 3 types of category: primary, secondary, and tertiary. Clinical use for gonadotropin, number 1, diagnostic testing. For diagnosis of adrenal insufficiency is this. We can use it to differentiate between primary, secondary, or tertiary. We can use it for treatment from infantile spasm, and sometimes use it for the treatment of multiple sclerosis, ACTH. I will repeat it. Diagnosis of adrenal insufficiency, children suffer from infantile spasm, and sometimes use it for multiple sclerosis. Here what we have, ACTH lead to the increased level of cortisol in our body. As you can see here, ACTH stimulate the adrenal cortex and increase cortisol. So what happened here, the patient may suffer from, when you prescribe gonadotropin to your patient, the patient may suffer from hypertension with the chronic use. The patient may suffer from peripheral edema. The patient may suffer from hypokalemia. Hypokalemia means decreased level of potassium. The patient may suffer from emotional disturbances and increased risk of infections. So all these side effects related to the gonadotropin. Okay, regarding the ACTH stimulating test, Okay, so when you can see here when we have primary adrenal insufficiency, okay, we have low cortisol, high ACTH. Okay, with the primary adrenal insufficiency, we have low cortisol, we have high ACTH. Okay, when we have secondary tertiary insufficiency, we have high cortisol, low ACTH. So maybe we can explain that here. When we have primary, what that mean for us? Low, we have in our body we have low cortisol. What that mean? When you have primary, the disease will be in the adrenal cortex, unable to produce cortisol. That's good. So if you prescribe ACTH to your patient, this is the test here. You prescribe it to the patient. The cortisol will remain low because the adrenal cortex suffer from a disease, unable to produce ACTH. Okay, the cortisol remain low. What happened to the ACTH in our body? The ACTH will be high because you prescribe it from outside. So if you have primary adrenal insufficiency, the ACTH stimulation test will be low cortisol, high ACTH. That's good. So moving to the second one, we have secondary. We have the lesion in the pituitary or on the hypothalamus. Okay, what that mean here? So the situation will be, okay, when you prescribe ACTH, the adrenal cortex will be normal. So when you prescribe ACTH, the ACTH will stimulate the adrenal cortex. This will lead to the increased level of cortisol. ACTH will be low because we don't have the ability to produce it from the inside. I hope this will clarify the concept about the ACTH stimulation test. Okay, moving to the next medication, next hormones, gonadotropin hormones. Here we are talking about the FSH, LH activity. We have several hormones here we need to remember. We ask about which of these hormone has LH activity. LH activity. We have human chorionic-gonadotropin, human chorionic-gonadotropin, HCG. Then we have a recombinant human gonadotropin. Okay, so this one has a LH activity. Equivalent, we have some maybe hormones has both activity, LH, FSH. We have it here, HMG. So HMG has both. So you can see here HMG, human menopausal gonadotropin, has both LH and FSH activity. Okay, then we have FSH activity only. We have recombinant FSH and urofolotropin FSH. Okay, speaking about the function of FSH, the FSH responsible for development of ovarian follicles, and LH responsible for the estrogen and progesterone development or production and induce ovulation. So you can see here we have function here for FSH responsible for development of ovarian follicles, LH responsible for the production of progestin and estrogen and induce ovulation. Okay, so we have here list of medication. We need you to remember which medication carry the activity of LH only. We have HCG, recombinant HCG. Which medication carry both activity? We have HMG. And we have some medication only FSH like recombinant or urofolotropin. Okay, the gonadotropin, here we have a list of medication. You can see it here. So we have it. This medication used for ovarian stimulation. Okay, this medication in female, use it for the patients suffer from male hypogonadism and infertility. Okay, when you prescribe this medication to your patient, this will increase the testosterone synthesis and increase synthesis of spermatogenesis under the effect of LH and FSH, LH respectively. Then we have some cases for diagnosis. We can use it. If the patients are from the cryptorchidism under sended testis here we have we can use it at the primary or secondary For the primary failure, no testosterone response. So we have it here like testosterone insufficiency or gonads insufficiency. Here that means the testes here unable to produce testosterone. So when you have primary, the lesion will be in the testes here. Okay, so we have the testosterone. We have no testosterone here. So even if you prescribe any maybe hormone to stimulate, but the situation we don't have testosterone, no testosterone. Okay, when you have secondary, that means we have the disease will be in the pituitary. The disease will be in the pituitary or in the hypothalamus, there. So if you have it in the hypothalamus and this one normal function, and this the disease here. Okay, when you prescribe this group of medication, the result will be stimulate, and this will lead to the increase or normal secretion of testosterone. Okay, so we use it for diagnosis between the primary or secondary failure of testosterone. If you prescribe it to the female or male, the situation will be overstimulation of the ovary and hyperstimulation syndrome, ovarian hyperstimulation syndrome, and could lead to the multiple birth in females. Okay, next hormone. So that this is number. So the first one I will type it here. The first one was growth hormone. Then we discussed with the growth hormone SST. The second one we discussed the gonadotropin-releasing hormone. The third, okay, the third one we covered the ACTH, and number 4 we covered the GnRH, and number 5 now we have prolactin. So we have now number 5. I will repeat it. We covered the first one, growth hormone, is SST, somatostatin, GnRH. Then we cover the ACTH, the GnRH, and then we have prolactin. This one repeated number 3 and 4, and for this reason. Okay, for the prolactin under the control of two hormones released from the hypothalamus, we have TRH, and then we have dopamine. Dopamine inhibit release of prolactin, and TRH stimulate release of prolactin. Prolactin affect the breast and induce milk production, especially during the breastfeeding and pregnancy. Prolactin, as you can see here, produced from the anterior pituitary and responsible for production of milk during pregnancy and lactation. So the only one case abnormality we can see with the prolactin, we have hyperprolactinemia. If you talk about hyperprolactinemia in female, the situation will be the patient here, the female patient may suffer from amenorrhea, galactorrhea, infertility, and delayed puberty in young girls. If you talk about males, this is associated with the decreased libido, galactorrhea, gynecomastia. When we have here hyperprolactinemia. Hyperprolactinemia, usually treat with something. When you have hyperprolactinemia, if you look on the table here, we have hyperprolactinemia. That means we have high level of prolactin. They said, okay, what happened? Can we treat hyperprolactinemia? They said yes, by prescribing dopamine. We don't have dopamine in the clinical practice for hyperprolactinemia. We have it for another cases. We have dopamine to treat patients from cardiogenic shock or from shock in general. But for the hyperprolactinemia, we don't use dopamine. Dopamine is not for the hyperprolactinemia. We use something to induce dopamine in our body. So what we have here, we have dopamine agonist. So we can see here we have dopamine agonist such as bromocriptine and cabergoline. So bromocriptine, cabergoline considered like a dopamine agonist, and this medication used for patients from hyperprolactinemia. Okay, we done with the hypothalamus, anterior pituitary gland, anterior pituitary lobe. We are moving now to the last part of the pituitary gland. We have the posterior pituitary lobe. We have two main hormones, as you can see here in the graph. We have vasopressin and oxytocin. This vasopressin and oxytocin are not regulated by releasing hormone. These two hormones synthesize on the hypothalamus. We need to focus on this one. So these two hormones, the oxytocin and vasopressin, synthesize and release from the hypothalamus, and this hormone will be transported to the posterior pituitary lobe, where it will be stored and released in response to the specific physiological needs. So this is what we have regarding these two main hormones, vasopressin and oxytocin. Remember, we need to remember that both hormones have very short half-life. We don't have it a lot in a clinical practice, but oxytocin is very important in the OBGYN and for the practice for delivery and pregnancy. Okay, if you look on the first hormone from the posterior pituitary lobe, we have oxytocin. Oxytocin work on something called the GPCR, stand for glycoprotein coupled receptor. Activate GQ protein, increase activity of IB, inositol triphosphate, and calcium, and this will lead to the contraction. And here we talk about if this target for oxytocin will be the uterine, and we can call that where the oxytocin stimulates the uterine contraction. Oxytocin is induce or reinforced labor. Oxytocin will help the milk ejection during lactation. Oxytocin could be used to control postpartum bleeding. So all these consider like action and clinical use. Stimulate uterine contraction, induce labor, enhance milk ejection from the breast. Any side effect here, there is a risk of toxicity, but this risk is considered like uncommon side effect, but if it happened, it's considered like serious and sometimes life-threatening. So you can see here the oxytocin, if you use it in appropriate way, oxytocin may lead to the uterine rupture. Oxytocin may lead to the hypertensive crisis. Oxytocin may lead to the water retention and to the death of the infant. So we have like uncommon but could be life-threatening: uterine rupture, hypertensive crisis, death of the infants to the infant, and water retention. Okay, so do you have any like adding agent for the delivery and pregnancy? The first medication for delivery and pregnancy here, you can see it. We have the methyl ergonovine. We have methergine here. This medication belongs to the ergot alkaloid and cause vasoconstriction. And this medication used to control uterine bleeding, postpartum uterine bleeding. So that's the first one, and this medication may cause from the ergot, because all the ergot, if you go to the migraine or ergotamine, all the ergot cause vasoconstriction and increased risk of blood pressure. So methyl ergonovine is that belongs to the ergot alkaloid and used to control postpartum uterine bleeding. Donabprostone belongs to the prostaglandin E2, prostaglandin E2. This one used for cervical ripening for the delivery or for the abortion. Then we have carboprost, and this one considered like analog for the prostaglandin F2 alpha. We need to remember this one. Carboprost, prostaglandin analog F2 alpha, and this medication used for the control postpartum uterine bleeding. So we have two medication for the control postpartum. We have one medication for the cervical ripening here. So if you click on the first link here, I will share with you what we have there regarding the dinobrostone. And from the name serfidil, and this one remind us with the cervix. And you can see cervidil denobrost like vaginal insert. Okay, so dinobrostone. We use this medication, okay, for the cervical ripening in pregnant woman at the near of term, in whom there is a medical or obstetrical indication for the induction of labor. So we use it here for the cervical ripening to facilitate delivery. This is the first one here. Click on the second one. Okay, we have here methyl ergonovine, and scroll down to see the clinical use, for example, for this medication. Okay, this medication used for following delivery, the placenta, the routine management of uterine atony, hemorrhage, and subinvolution, and so the situation here, the key word to control uterine bleeding. So methyl ergonovine, remember that methyl ergonovine and carboprost used to control postpartum uterine bleeding. Okay, so the next we have the last hormones produced from the posterior pituitary lobe. We have vasopressin, and vasopressin, we have another name for vasopressin, antidiuretic hormone, ADH, and belong to the arginine vasopressin. They try to remind us we have two main receptors there. We have V1 and V2 receptor, and we talk about V2 mainly available in the kidney. So V2 mainly available in the kidney are responsible for the absorption of water. V1 mainly responsible in the blood vessels. So here we need you to remember we have V1, we talk about blood vessels. V1 receptor, then we have V2 receptor, this one available in the kidneys. Okay, so this one is very important for us, and when we activate V2 receptor in the kidney, the result will be enhanced absorption or reabsorption of water in the collecting duct. So the collecting tubules, that's the question, another question, where is the location of vasopressin in the kidney on the collecting duct? Okay, moving to the again for the regarding the vasopressin, I will repeat it here for vasopressin. Vasopressin, we have another name, ADH, antidiuretic hormone. We have two receptors, as you can see here. We have V1 receptor work on the GQ and activate IB3 calcium. V2 receptor work on GS, activate cyclic AMP. Vasopressin has antidiuretic effect and vasopressor effect. Vasopressor mean increased blood pressure or vasoconstriction. In the kidney, binding to the V2 receptor, the result will be a reabsorption of water in the collecting duct. The vasopressin could be used for diabetes insipidus. Vasopressin could be used for the control bleeding due to the esophageal varices. So two cases could be used for in vasopressin. Number one, diabetes insipidus. Number two, controlling bleeding due to the esophageal varices. Here, because from the name antidiuretic, patient may suffer from water intoxication, patients may suffer from hyponatremia, abdominal pain, and stimulate uterine muscle contraction. Okay, so we already covered the vasopressin, and when you cover the vasopressin here, we can look what we have there. You can see vasopressin considered like non-selective. Vasopressin considered like non-selective agents because affect two receptor, affect V1 and V2 receptor. Okay, for this reason here, the pharmaceutical company developed something for the practice more selective. They developed desmopressin. So desmopressin mainly affect V2 receptor in the kidney. Okay, so mainly affect and desmopressin has a minimal effect on the V1 receptor. So no effect on the V1 receptor or minimal effect on V1 receptor. The main effect will be on V2 receptor. We know that V2 receptor mainly available in the kidneys, and the result will be to enhance water reabsorption. And we use it for patients from diabetes insipidus, for nocturnal enuresis, for children above than 6 years, for renal concentration capacity test for children above 3 years old or equal. Okay, so the situation here, as you can see, regarding, I will repeat the desmopressin again for the, as maybe recap or summarize the information about desmopressin. Desmopressin has minimal effect on the V1 receptor. Okay, desmopressin has a less effect on the V1 receptor in the blood vessels. Desmopressin considered like renal selective agent, preferred to use for diabetes insipidus. Desmopressin has longer duration of action if you compared with the vasopressin. We use it for diabetes insipidus, central diabetes insipidus, nocturnal enuresis in children above 6 years old, and renal concentration capacity test for children above 3 years old. There is a risk of water intoxication, hyponatremia, bronchoconstriction, tremor, and we need to be cautious about patients from coronary artery disease, asthma, and epilepsy. Okay, this will conclude our lecture about the hypothalamus and the pituitary gland. We cover the hormone released from the hypothalamus, such as GHRH, GnRH, TRH, and other hormones such as BRH and BIH and somatostatin. All these hormones, the pituitary hormone, about the TSH, ACTH, and so on. Thank you for listening, and have a great day, everyone.